So we are talking about Phakic IOLs, and in Phakic IOLs, we would define the audience in two type of categories. One, who are planning or have just started using Phakic IOLs, and the second category would be a little more advanced, where they are already using Phakic IOLs. There is a couple of options available in the market. It's not possible to have that many volumes to understand all the options so comfortably. So maybe some merits and demerits of somebody's experience could help you decide how are these options faring in the market. So we start with the first presentation. I'll show you the four options. So we are welcoming you again, and we are talking about the four Phakic IOLs. The most popular of these is the ICL, also known as the EVO ICL. It is called first the EVO Vision ICL, but now they have dropped the name Vision, so it is EVO ICL. And we are showing how we do this under hydro insertion. So you see two options, the hydro insertion and the visco insertions. So this is purely under hydro insertion. You make the ports, and when you make this main port, the eye should be firm or tight. If the eye is loose, you may hit the anterior capsule. Load the lens, and now the irrigator is what is maintaining the chamber pressure at an IOP of 40. It's a low IOP, 40 or 50. The lens is injected over the iris. Since it is hydro insertion, there is virtually no visco. Just a few threads which were in the injector cartridge, which just come out in 5 seconds. So it's virtually visco free. And then you tuck in the haptics. The whole surgery takes just about 5 minutes. And the biggest advantage of hydro insertion is that the fear of a raised IOP, first day post-op, is over. We have not seen in the last 3 years any case of a raised IOP post ICL in the first week. Talking to a lot of people who started using ICLs, the raised IOP is a major issue. The IOP goes high, the patient is complaining of pain, the cornea becomes hazy, the vision is not too good. The patient expectations are very high because now they are using a procedure which is almost twice the cost of the laser procedure. And if he does not get immediate good post-op vision, he is demoralized. And the surgeon is even more demoralized because he is marketing a procedure which is so expensive, as if it is a miracle for the patient. So we realized with time that this technique of hydro insertion comes naturally if you do the first 5-6 cases, and then you would not want to revert back to the visco insertion at all. We'll come back to it again later. Now, this is the biotech Phakic IOL. We do it under hydro insertion also, but here I would be showing you visco insertion. So we'll show you both the sides of the same coin. So this is visco insertion, the technique which we are most used to doing. The incisions in all my Phakic IOLs I've kept at 3.2. So the eye is now firm with viscoelastic. The advantage of visco insertion is there is a little more control in your hands because the chamber is very stable all throughout. So maybe for a beginner, we would recommend a visco insertion because at that time you are still fumbling. Now this is a biotech lens. It looks exactly like a star lens, except that the holes are left leading, right trailing. In star, it is right leading, left trailing. And in star, the axis is on the vertical edge. Here, the axis can be in 5 different meridians. So you just have to move the lens by about 15 degrees either side. So you could have at 45, at 90, at 135, at 0, 180. So here you see, this is the axis mark, which is at 90. Lying in the eye right now, it looks exactly like a star ICL. This is the hole in the left leading. The manipulations for a beginner are smoother, definitely, in a visco insertion. So probably your first cases should be visco insertion with this inherent fear that you may have a rise of early IOP and bringing the lens into position. So actually, inserting an ICL is not a very great surgical technique, but it comes with a great amount of fear in the mind of a surgeon. The fear of cataract, the fear of glaucoma, the fear of the ICL hitting the anterior capsule, the fear of what if this young patient develops a cataract, he'll be after my life. You're dealing with very young eyes and you're promising them a lot. And the parents are very sensitive about their children. Very, very sensitive. They are not that sensitive about an old man who's undergoing cataract, but they are very sensitive about the kids. So that is where the surgeon's fear develop. Then we have this IPCL from Care. Again, I'm going to show you a visco insertion. Now, IPCL is comparatively when you feel a thinner lens. Star is the middle level lens, which is very comfortable to manipulate. Biotech is a thicker, harder lens. Care is a thinner, even more flexible and a soft lens. It is almost kind of a little uncomfortable to manipulate around because whenever you press it, it gets pressed the whole way. But other than that, it's a good lens. Now, this is the typical shape of this thing, left leading hole and a mark here in the left leading, mark here in the right trailing. And there are these two holes here because each manufacturer has to have something different. So it's not a copyright infringement. So these two holes come under the upper lid, always. So you have to be careful that you don't put the lens in such a way that the holes are facing down because then they will come into the visual area. These two holes have to be covered by the lid. So insert and let it open up slowly, again over the iris. Now the lid is here, so these two holes are always placed superiorly. Now these are smart lenses. That means you are always putting it at 180. And they come with the pre-built axis. And there is no way to know that in a lens where the axis is. You are assuming from the box that what you ordered and what you have got is what the axis is. And it's right. But you have to depend on them that they are delivering the right axis. All you have to do here is remember that this is a smart lens. When you say smart, you're always putting the lens at 0, 180 and trusting that the company has put the axis at the right axis. And that the result will tell you on the next post-op day. So you don't have an option that you can turn the lens around to the right axis or whatever, nothing, just 0, 180. Since it is a thinner lens, we have a tendency to use it. Since it is a thinner lens, we feel tempted to use it in powers which are beyond 18. So 1 to 18, or you can say 8 to 18, because 1 to 8 is usually LASIK. 8 to 18 is Phakic IOLs, which by choice we go for the star ICL because of the brand value. And then when it is beyond 18, we tell them that we don't have a star lens in this range, so we are opting for the other ones. And the patients accept, rather than doing a bioptic. That means you put 18 powered ICL and then you do a lacing on the top. Why do two procedures when in one lens you can cover the entire number? So biotics have gone out of a curriculum now because we can correct up to 25, 26, 27 with the phakic IOLs itself. And that makes a lot of difference and makes a lot of sense. And when we do these higher powers, we have biotech, which is local, they can customize, and the care group, which is local and they can customize. So if you have very high powers or high cylinders, 5, 6, 7, 8, one has to depend on these lenses and they deliver. All the lenses deliver. That is there. Somewhere there will be minor variations, I would tell you. Now this is a medium phakic lens. Previously it was launched as the PRL, phakic refractive lens. Now it can correct up to minus 28, but it is only a spherical lens. Why spherical? Because it does not go into the sulcus. It is a shorter lens and it is kind of floating in the center. Now, if it is floating in the center and it is a shorter lens, you would wonder, how does it stay in the center? It could just flow to one side. So the technology which they say works is like a parachute. In a parachute, at the top of the parachute is a small hole. And then when the air from below moves up through the small hole, it stabilizes the parachute. So this also, when the fluid is moving from inside upwards, it stabilizes the lens in the center. And that is why the lens does not fall to one side or to the other side. We have used about 20 of these and they worked. We were apprehensive that there's a lot of talk, but does this technology work? The technology worked. So now we are going to inject this lens. This is a silicone lens. Compared to others, which are HEMA lenses. So this is the lens, the central optics and the side flanges, which are not reaching out to the sulcus. Since the haptics are smaller, I could tuck both the haptics or the plate at one time. And then I constrict and the lens stays in the center. Why we have almost stopped using these lenses is because we were using these lenses when the powers were high, 25, 26, 27, 28. And almost 100% these high powers are associated with the cylinder. Almost. Anything more than half is what we correct. But they usually have a cylinder of 1, 2, 3. All these very high powers. And since we have started getting these care lenses and the biotech lenses in the same range with the cylindrical correction, the need for these lenses, we don't find it of any definite use in our clinical practice. So, I would ask Dr. Rahil. Dr. Rahil, are you ready? So, before we move on, we'll give you a little idea about a workup, just the salient points in a workup of what is important in your ICL practice, and then we'll take you to the higher levels. The higher level would be cataract and glaucoma fears. That is the main thing that troubles the mind of every ophthalmologist. What if there is a cataract? What if there is a glaucoma? How do you prevent it? The aspect on prevention is more. Can you take the dice? The aspect on prevention is more than the aspect of treatment, because treatment of cataract has to be a cataract surgery. So we will be focusing more on the prevention part. Then I will take you into the details of hydroinsertion and viscoinsertion, merits and demerits of both. And then we will actually compare the 4 Phakic IOLs. So I have Dr. Rahil Chaudhary. He is again in Delhi, one of the directors. Yeah. Okay, I would do that. It is what's not in this, but I have videos on that. So I'll spend some time to show you how to take out those lenses. So I have Dr. Rahil. Dr. Rahil is also the director of I7, and not that he is my son, but he's also a prolific surgeon, and he has kind of set a new system rolling, a system of how you spread the word through digital marketing on the new trends of getting patients to your practices. So, but for that, it's a different topic for him. Right now, let's hear him about some salient features of how to plan a Phakic ICL. Dr. Rahil, please.
Hello everyone, good morning, and I'll be discussing basics of how do you work up when you're looking at a phakic IOL patient. So this is a star ICL on the tip of a fingertip, and when you show this to your patient, it is very convincing and satisfying for the patient to actually see what is the size of this beautiful lens. And then this is another image which I use to counsel my patients. Where would the lens be going inside the eye? So it goes behind the iris and in front of the natural lens. So all these pictures help patient understand how the technology is working and how the technology is addressing the myopic power of the patient. And then this nomogram has been pasted in my OPD, and it takes away 50% of my counseling time. This is a nomogram that works in 90% of the patients and help the patient understand very clearly that which option would suit him the best. So we say that till the time your specs power is or refraction is between -1 to -8, the procedure of choice is usually a laser based refractive surgery. And in our hospital, our preference is usually LASIK or Contura, which is topo guided LASIK in eligible candidates. And then when the number goes beyond that, when you have powers between -8 and -18, then the preferred choice would be a star Evo ICL. And it is very comfortable for the patient to accept it, provided that the star Evo ICL is US FDA approved. And then when we go powers even beyond that, like already discussed, when your power is between -18 up to -25, then you have a choice of biotech or care phakic IOLs, in which care phakic IOL is a thinner IOL, can be used in very high powers, but even biotech works equally well. And then when you have hyperopic patients between +1 to +4, usually the recommendation is a laser based refractive surgery. And the moment you go beyond that, you can also go ahead with the ICL or RLE procedures. The machines today allow corrections up to +6 for hyperopes, but it is preferred that you keep it up to 4 and not go beyond that because of unnecessary symptoms that appear after that. Now, in ICL workup, this is the most important step when you're evaluating your patient for an phakic IOL or an ICL surgery. There are some mandatory things that you have to check, probably double check, which are refraction, and the refraction has to be a proper dilated refraction. Then you need wide to wide for your ICL sizing, and then you need an adequate anterior chamber depth so that the ICL is cleared from the crystalline lens and the endothelium. Then, of course, other checkups in which your retina checkup is the most important, because usually ICLs are being implanted into people who have high myopic powers, and in high powers we often suspect lattices, holes, or weakening in the retina, and if you ignore them, sometimes your patient can land up in a retinal detachment. So it is very important to do a thorough retinal examination. Endothelial cell count, again important, axial length, keratometry, and dry eye status. So this slide just helps you to do a mental calculation when your ICL has been ordered. So you can just calculate in your mind that suppose the power is between -1 to -18, the correction would be somewhere from 0.75 to -18, and so on. And the rough idea, when you have an ICL in your hand and you're about to implant it, you can have a basic rough calculation in your mind that ICL power is approximately 1 diopter more than the spectacle power. So suppose a patient that you're operating has a power of -9 diopters, you should have approximately a -10, a 10 diopter ICL in your hand. And when you're doing your mental calculations and just analyzing if the ICL has been ordered correctly, because you don't want to land up into surprises and an ICL exchange. So how does the calculation work? So basically the minus cylinder is transposed to the plus for cylinder calculations. So suppose a person has a power of -12 with -6 at 90. Now you have to transpose this power, and the ICL that would be ordered would be -18 with +6 at 180. So of course you don't have to worry too much about it. You have softwares to help you do these calculations. But let's say suppose you have a patient of higher power and you are planning to implant an star ICL. Then let's say suppose the patient comes to you with -16 with -6 at 90. So then this power would not be accepted as -22 with +6, because that is beyond the correction. So it will be accepted as -18 with +6 at 180. Now, when you are sizing your ICL, it is very important that the appropriate wide to wide distance is taken correctly. And usually this is how we follow the size of ICL. And when you are sizing the ICL, just for a rough calculation in your mind, you should remember that the ICL size is approximately 1 millimeter more than the wide to wide. And how do you measure wide to wide? So of course you have different instrumentations. You can do it with a digital caliper, which is highly reliable. Then you can do it with an optical biometer, something like a lens star. Also you can do it with a pentacam, but vernier calipers should be avoided. And usually the confusion is that what is white to white, what is black to black, what is gray to gray. So when we are sizing ICL, we are looking at white to white and not gray to gray and black to black. So I've marked here. So you should, when you're taking the measurements, you should have an idea of what exactly are you measuring. And usually digital caliper works wonderfully, but then it is also important to verify that if your measurement is accurate or not. So do the measurements with a digital caliper, then do it with a pentacam, and the pentacam reading should be approximately 0.2 millimeter higher. and then do it with an optical biometer like a lens star, and the reading should be about 0.5 millimeter more than the manual calculation. So suppose when you're sizing your ICL and you get measurements like the digital caliper is giving you 11.8, the pentacam is giving you 11.9, and the lens star is giving you 12.3. That means your calculations are bang on. Now, sometimes you would have these confusions in your clinical practice that let's say the measured value was 11.6. So you see here that at 11.6, the size is 12.6. And the moment the white to white becomes 11.7, the size changes to 13.2. Now, this is where the confusion lies, that which ICL to actually implant, which size to choose. Should we go ahead with the 12.6 or should we go ahead with the 13.2? So, the first thing you can do is, of course, talk to the star people. They will help you. But again, you can do a gonioscopy and you need to see the angles. Suppose the angles are open, they are wide open, you can go ahead with the higher size. And if your anterior chamber depth is good, it is more than 3 millimeters, like somewhere around 3.3, 3.4, again, you can choose a higher size. But the minimum anterior chamber depth that you need to implant a phakic IOL is 2.8 millimeters. Below this, it is better to avoid it. And what are the ideal tools for measuring ACD? So, of course, pentacam, highly reliable. But of course, you can get it done with an A scan also. But sometimes you have to be very careful that from which point are you measuring the ACD. You have to remember that this measurement has to be from the endothelium and not the epithelium. And of course, you have optical biometers and OCT to further refine your measurements and accuracy. Thank you so much.
Thank you, Dr. Rahel. I'll ask you a couple of questions and the audience are free to ask for questions. In the meantime, I'll ask Dr. Sarika to be ready with the next talk. Any questions for Dr. Rahel before I ask Dr. Rahel some questions? Arun, I'm on the dais. I'll talk to you later. Right.
If the ACDF test 2.75 or 2.7,
So usually for beginners, we are recommending that at least 2.8 should be the depth. But somebody who in the experienced hands, we are also pushing it down to 2.75 in our centers, but not below that. Below 2.75 is an absolute no. Sir, but still again below 2.75 is kind of risky and better avoided. No, in 2.782 we can just put the lens like that. Doesn't become a problem.
Actually, till 2.7, now we are putting the lens. Of course, this is 2.8 is the recommended guidelines. So you are taking your own risk when you're putting 2.7 without any fears. But it is not officially allowed to put 2.7, right? Because nobody will come to your help if something is not going right. But between 2.8, our cutoff is 2.7, though of course we like to keep it above 2.8. What we do is we have a lens star, we have a pentacam, and we have what is called an anterion now. The anterion is taking images on the visual axis, not the optical axis. And so its ACD readings are about 0.2 more than the lens star. So that 2.7 is covered by the anterion, which was not getting covered officially on paper by the lens star or the pentacam.
But also, I would like to add that in myopic correction, sir, we are not making PIs in any patient now. So all the newer lenses have that centra hole and it works perfectly well. Even in when we are implanting it in a 2.7 or let's say 2.75, we are not making any additional PIs.
so same question, when the white to white, the lens diameter changes after certain time, like in 11.7 or 11.65. What will you prefer, a bigger lens or a smaller diameter?
No, sir, it actually depends. Suppose you have a controversy between 11.6 and 11.7. then it is very important that you do a gonioscopy and see the angles. And suppose the angles are open and you have a good ACD, then it is preferred that you go ahead with a higher sized ICL. But suppose you don't have enough ACD in hand, or suppose the angles are not very widely open, then it is preferred that we go ahead with a smaller size.
Actually, I will just answer that again. If you have a spherical lens, go for one side slower. Because even if it moves a bit, it's not a problem. If it is a toric lens, up for a size higher because you need it to fix tightly to the sides. Assuming that other parameters are within acceptable limits. Okay, now you're asking one question.
Sorry, come again, sir.
A different type of optical biomarker. Suppose the blood star and IOL masses.
Sir, I am used to working only on the lens star. I think you have
but
any, you have
there is no
you have
difference
IOL
at all.
marks. So
Like I told you, in all optical biometers, there is no difference at all. The readings match perfectly to 0.01 or 0.02. They are so accurate, all of them. But there's only one biometer which is giving a difference of 0.2 only in the interior chamber depth readings. That's it. That is the interior one. Otherwise, all biometers are very precise. That's the marvel of technology.
So I think you are using all the three lens star IOLs, Master 700 and the interior one
And the interior, yeah.
to do the white to white, but all the readings are exactly the same.
Yeah, exactly the same.
You prefer the biometer or the manual micrometer? Which will give you the most confirmed
So,
See,
so
the manual-
caliper, the digital caliper.
I would put it the other way around. The automatic system is more dependable because the system is in the hand of your optometrist. Manual white to white, you could be measuring 4.5 or you could be measuring 4.6. You would never know. You can never be that precise. Right? Your hand is moving, it is stable, it's a different perception. The optical is going through the translucent area and is getting blocked by the transparent area at the limbus. So, but the optical one can have errors because of pigmentations or opacities at the limbus. So the manual is double checking those errors that you're not making a gross error there. So the manual is a must. But when you take a glance and your manuals are matching up with your optical, you are comfortable that you don't have to go and check. It's already there. Yeah, Cirrus is again coming up to be very good in white to white. True. Yeah. All these machines are taking white to white. They're actually taking white to white. They are not taking gray to gray because gray to gray is a bigger zone. It's almost a 0.3 millimeter zone. So how do you define gray to gray to a machine? Your machine cannot define less gray and more gray. Yeah. So machine is doing white to white. It can only sense a clear opaque area from a translucent area. Right? So that is why now we have reverted back to white if we have to relate our readings to the machine readings. At one time, we were propagating all horizontal visible iris diameter. That means clear to clear. Then we went mid to mid. And now we are going actually white to white.
That means you're totally dependent on the lens or masters. Or you counter check again with digital.
We counter check with digital. We see those readings and we check with digital. If the two are matching, we are comfortable. We just want to know whether those readings are not fallacious because of some other factors.
But what trial subtraction you gave from the optical diameter, you reduce so much to the digital, many times doesn't look like.
That will always be there. Why? Because the white to whites is a corneoscleral tissue. And the angle to angle is a uveal tissue. and it is not necessary that the uveal tissue is going to match the contours of the corneal tissue. So that is why you have surprises and you have high walls and low walls. That will always be there. It's just an approximation, no? That you're going into a blind spot area and you don't know what are the dimensions of the blind spot. Even we know that horizontal is wider, is bigger, vertical is smaller, and in 50% it is equal. So which one is going to be equal, which one is going to be horizontal, more angle distance than the vertical, and in some cases vertical is more than the horizontal. That is established in journals. So it is all subjective, it is all in the mind. We are just hoping that things go right, but sometimes they just don't.
Have you ever counter-checked it with the ASOCT surface to surface?
We are doing ASOCT in every case,
And
pre-op and post-op.
ciliary body to ciliary body?
Yeah. So we have found some differences, that the white to white, where we found that the lens was very loose or very flat, we found that the angle to angle or the spur to spur was much higher than the normal ratio of a difference of 0.2. So we are working on that, but yes, there are differences. Definitely there are differences.
Now you are totally dependent on the anterior.
We still use the three systems, but we finally depend on the interior because it is a ray tracing system.
And I must have 700. All these are rate tracing systems.
No, this is not ray tracing. Yeah. Of? See, vault is dependent on two things. The vault is the distance between the lens and the ICL. Now, it also depends on the lens rise. So if the lens rise is more, your vault will be less. If the lens rise is less, your vault will be more for the same situation and the same fitting. Nahin? So that is relative. What is more important is to actually see what is the gap between the ICL and the endothelium. That is going to be fixed, and that is important. It's the other way around. See, as you think more, think out of the box, you start realizing that one is what is taught to us, and one is when you start doing volumes, you start thinking beyond what is taught to us. No. So vault is a very variable thing, depending upon the lens rise. Whereas the endothelium to the ICL ratio is the one which is more relevant. And how much did we get that difference? Right? So we move on to Dr. Sarika's talk, and Dr. Sarika would be talking to us about what fears an ophthalmologist. And the number of fears, the lens may rotate and other things, but the main two fears why ophthalmologists don't want to embark on phakic IOLs is the fear of glaucoma and the fear of cataract. And let us see if we can overcome these fears with Dr. Sarika's talk. Dr. Sarika, please.
Hi, good morning everyone. So today I'll talk about how to overcome the fear of cataract and glaucoma after ICL surgery. So there are two main reasons for cataract formation after ICL
A
surgery.
little louder, please. You can have the mic closer to you.
Yes.
Yeah.
So there are two main reasons for cataract formation after ICL surgery. First is ICL and crystalline lens touch, and the other is excessive irrigation or irrigating fluid jet hitting the anterior capsule. So first I'll discuss about the one which most of us are aware of and afraid of, that is ICL and crystalline lens touch. So I'll discuss about both the scenarios. So now first so this is a case of minus 30 diopters patient which we operated upon 15 years ago. We did his ICL surgery and we did it with the ICL without holes, that is V4 model. So this is how his vault was. It was very shallow in the periphery, and in the center we had an ICL crystalline lens touch. So 15 years ago, we didn't have much experience whether we should just continue with this ICL, exchange it with the higher volt, or just observe. So at that time, we decided to just observe and follow up the patient. We asked the patient to come for a yearly follow-up. So it went on very well for a couple of years until in the 5th year of follow-up, we noted this speck on the anterior capsule of the lens. This speck on the anterior capsule was very peripheral. So it was basically anterior subcapsular cataract developing in the periphery. It was very peripheral and small, and it was not affecting the vision. So we decided to observe it. And the patient again followed up with us on yearly basis. It went on very well for another 5 years. Until in the 10th year, the patient developed the central cataract in both the eyes, and we did his both eye ICL surgery. So in this case, what I want to focus on is that the patient has a ICL crystalline lens touch right from the very beginning. And the model was old V4 model without the holes, and it worked very, very well for 10 years until we had to do the cataract surgery. So here is another case, similar case with old V4 model where we did the ICL implantation and we got another anterior subcapsular cataract. This cataract also developed in the 5th year of follow-up. So this is the anterior subcapsular cataract as seen in the retroillumination, diffuse illumination, and slit lamp illumination. And we did his cataract surgery after 5 years. So all these cataracts developed with the old V4 models. And we have started using newer V4C model, that is ICL with hole, since 2014. And we have not encountered a single case of cataract since then. Even if we have volts as low as 84 microns or 100 microns, we are seeing the patients on follow-up, they don't have any anterior subcapsular opacities. So this is how we counsel a case of patient who asks us about the risk of developing cataract after ICL surgery. We tell the patient that the cataract happened in early V4 models, that is ICL without hole. It does not happen with the newer V4C model, that is ICL with hole. And that there are several studies which mentions incidence of cataract as 0 in last 5 years. The incidence of cataract is actually as low as 0.1%, which is safer than going out on the road. So we tell these patients that since the advantage of ICL is huge and the risk of cataract is so small, this risk is worth taking. And we tell them, even if in rare situations cataract does happen, it can be managed very well with the cataract surgery without any visual loss. So another cause of cataract formation, which most of us are not aware of, is excessive irrigation or fluid jet hitting the anterior capsule. So this is the picture of the patient on the first post-operative day after ICL implantation. We saw the whitish deposits on the anterior surface of the lens. These are the whitish deposits as seen on the slit lamp illumination, diffuse illumination, and retro illumination. At first, we thought that these were the retained viscoelastic material which has caused these white deposits. These deposits decreased over a period of time, and at 3 months follow-up, they had almost disappeared and there was no vision loss. We saw 3 to 4 such cases, and we thought if retained viscoelastic is the problem, why don't we stop using the visco and start implanting ICLs under hydroinsertions? So we stopped using the visco and started doing hydroinsertion of the ICL. So after we started the hydroinsertions of the ICL, 3 months later, we saw a similar such case where we saw the white deposits on the anterior surface of the lens. So on follow-up, like the previous cases, these deposits decreased by day 30th without any vision loss. It really got us thinking what it was, because the amount of viscoelastic we were just using viscoelastic in the injector to load the ICL, the amount of which was very minuscule, and that too we were washing with the hydro. So how can such a small amount of viscoelastic be deposited on the lens? We kept on wondering, but we didn't find any answers. So 1 year later, we saw another case with huge amount of deposits on the anterior surface of the lens. So we checked up the literature and we found a case report which mentioned about the vacuolar changes on the anterior subcapsular space of the lens after irrigating procedures during the phakic IOL implantation. So it mentioned that the vacuolar changes developed just after the irrigating procedure through the narrow space between the ICL and the crystalline lens. It also mentioned that these whitish deposits appeared like bleb-like lesions as seen on the ASOCT, and that these lesions gradually improved without visual deterioration. So we also went ahead and did the ASOCT of our patients, and we saw similar bleb-like lesions. So from all these cases, we learned that retained viscoelastic was not inducing, it has no role in inducing cataract, or these were not inducing subcapsular vacuolar changes in cataract. It was excessive irrigation that was causing transient anterior subcapsular vacuolar changes on day 1, which would improve with time without any visual loss. But the main thing to learn here was that during hydro insertion or visco removal, even if you're doing it under visco, during visco removal, never irrigate between the narrow space between the ICL and the crystalline lens. Because when you irrigate between them, you hit it with a lot of pressure, and these causes vacuolar changes. You should also keep the irrigation flow and irrigation time to minimal, and your IOP setting should be low and the bottle height should be low so that there is this less strong irrigation jet. So another fear is that of glaucoma after ICL surgery. So the 3 main causes of glaucoma after ICL implantation surgery are retained viscoelastic, high vault of ICL, and the ICL placed upside down. In the immediate post-operative period, one can get high IOP because of the retained viscoelastic. The retained visco can clog the drainage channels, which requires IOP lowering agents until the viscoelastic is washed off. Now coming to a very important thing is high vault. The vault is generally called as high if it is more than 1000 microns. So if we get a high vault, what we do, like we are always in a dilemma whether now we should exchange the ICL, just observe it, or remove it. What we do here is we do the IOP monitoring of the patient and we check the angles on gonioscopy and ASOCT. If the IOP is normal and the angles are open, we wait and watch. And if the IOP is raised and the angles are closed, we replace it with a one size smaller. So I'll show you the case scenarios. Here we had a patient of vault up to 1400 microns, but his IOP was normal, and as seen on the ASOCT, the angles were open. So we decided to follow up the patient, just observe the patient, and after 1 year of follow-up, the IOP is normal and the patient is doing absolutely fine. And also, if you get a very high vault, there should be no hurry in exchanging the ICL. If the IOP is normal, here is one such case where we observed that how the vault decreases over a period of time. When we saw the patient on the first post-operative day, the vault was very high. It was 1583 to start with. After 1 month of follow-up, it decreased by 100 microns. By 8 months, it decreased by 165 microns, and by 14 months, it decreased by almost 350 microns. So there should be no hurry in exchanging the ICL as the vault decreases with time. So now coming to another scenario where we did have to exchange the ICL. This is a case, this was an extreme case, like we had a very, very high vault where the ICL was vault was so high that the iris was touching the endothelium of the cornea. And when we did the ASOCT, we saw the angles were absolutely closed. So we went ahead and immediately removed the ICL. The surgery was very challenging. And the AC was so shallow that there was ectropion uvea as the ICL was pushing the uvea from below. There was no space for manipulation. We didn't have even space for the side ports to enter. So we opened up the same side ports. So there was hardly any space for manipulation of the ICL. Normally, when we have to exchange the ICL, we bring out one of the edges of the ICL into the anterior chamber and then pull out one edge. But since here, in this case, there was no space for the ICL edge to come out, we just managed to grab one edge of the ICL and just pull it out of the eye. We then implanted the ICL with the one size smaller, and this is how the vault was after the surgery. So last but not the least, I'll show you a case of ICL placed upside down causing glaucoma. This was a case done elsewhere, and we saw this patient 5 years ago. When the patient first came to us, we saw that they were peripheral anterior synechiae and the AC was very shallow. So when we dilated the patient, we saw that the ICL was placed upside down and the CD ratio was 0.7. So the patient had glaucoma. We put the patient on the IOP lowering agents and we did the surgery. We tried to break the peripheral anterior synechiae, but we were not successful in doing that. So we brought out one edge of the ICL into the anterior chamber, pulled the ICL out, we turned around the ICL, brought it into the right configuration and re-implanted the same ICL in the eye. And the patient is doing absolutely fine now. Thank you. Sorry? This is the ICL holding forceps. No, there is one, when we do the IOL cutting, there is one separate forceps for holding the IOL. These are the IOL holding forceps. When we have to cut the IOL.
This is with epsilon, and it comes as the IOL holding and
Cutting forceps.
So there you need a very strong grip on the IOL if you have to cut it with scissors.
This is round in the front and very blunt. So once I tried using some other forceps and I broke one of the edges of the ICL. So these forceps are very, very safe. They are very blunt and
Which is the brand of this forceps?
epsilon.
Epsilon. It's Dr. Chaudhary's forceps. Okay. So, the normal ICL holding forceps are those alligator forceps. The problem with those alligator forceps is it's very long. And when you try to hold it, sometimes you tend to push with either the lower one or the upper one. And the lens moves a bit, and then when you grip it, it is not exactly aligned and it opens up a little bit sideways. So we changed the forceps design to make it a little smaller with a very good grip like what you saw now. so that we just go and hold and bring it out. The forceps does not push the ICL in the cartridge. So the alignment always stays perfectly in one line. So this forceps is working very well for us. Any questions? No, this is a very important topic, Dr. Dhami here.
You talked about the fruit species created by
Dr. Sarika, would you like to come here? You can answer from here only as panel discussion. Yeah, Dr. Dhami, sorry.
that's beautiful AIOCT of the intake capsule and a very good concept that you carefully irrigate after putting the ice. But this accelerates what you call as little material under the lens usually comes after one particular ICL, that is IPCL. Not all.
No, I didn't get you. Just come again.
You mentioned about the irrigating fluid.
Yeah.
Make the subcapsule spaces.
Sublenticular space. Huh.
Very nicely elaborated and said. But the second thing that there is a whitish material collected over the surface of the capsule, the lens capsule, is very particular with IPCL on the first, second week. No other ICL.
We have not noticed.
I have really not experienced that.
How it can be related with that particular lens?
Because it comes only from the surface. That's why we start putting that.
See, in between with this lens, there was a problem. We know about it.
Been given from around it.
Yeah, but as such, we have never seen something like that happen. Maybe our volumes of IPCL are not too high. We are just using it very high powers.
That's how we start.
We only use it in very high powers, and that too, our biotech lenses are more in use than the IPCL, because the biotech lenses had a cylinder accuracy in these high powers, which was initially it was a little erratic, and then when we started giving them the feedbacks, they started correcting their powers in their nomogram, and now the nomograms that they are using gives us a fair good correction. Suppose you have a number of -25 with -3 cylinder, or -22 with 6 cylinders. The biotech's accuracy is pretty good, plus minus half. The other company, the accuracy is still wanting, because these ranges are very rarely used, and their normal ranges, they work well in all the lenses, but these extreme ranges, they still have to customize their powers, and we find a lot of difference with the other company. So that is why we have done it with hit and trial with one company. Now we don't have the heart to again do a hit and trial with another company. So we are using biotech lenses more in very high powers. Though technically I would prefer the thinner lenses, the Care lenses in high power, because in any case your lens thickness is becoming higher in higher powers. So if the lens is thinner, it makes more sense in the same ACD. No? So that is why I would prefer the Care lenses given the choice.
One more question about the rotation of the lens. A patient comes to you, he has been implanted about a month back, a spherical ICL, and he comes with a good cylindrical power now to you.
A spherical lens comes with a cylinder power.
Could it be rotation of the lens? Could it be inflammatory cause? What can be? Because the only thing we could note was the decrease in the lens and the ICL and the lens capsule. Means what?
Could it be a subluxation of the lens, or a damage to the zonules, which is making the lens, the crystalline lens, tilt? See, if the crystalline lens tilts, it will cause a cylinder. A spherical lens, if it moves around, it cannot induce a cylinder unless it tilts. And any lens which tilts will cause a cylinder. So either the crystalline lens is tilting or the phakic lens is tilting.
So what was the magnitude of the cylinder?
Approximately 3.
3.
This is anecdotal, one case.
First one case, he is a doctor who has been operated elsewhere. And very difficult to explain to him because he understands everything. Should he be advised to get lens explanted or located in
Who would bill the cat?
the man who has put him?
So you send it back to him, na? With advice.
I think we need to do some workup on that, so like calculating where from where this is coming.
A good ASOCT, like the Interion, which gives
Society shows no wall.
no, which shows the lens, the crystalline lens alignment. It will also show the ICL alignment, because the normal ASOCTs, which are basically retina OCTs, will give you only a thin strip of the ASOCT area. It's only the Interion, which is a dedicated one, which gives you right from the epithelium to the posterior surface of the lens. You have the whole OCT area. So that gives you the exact alignment of the lens in the eye. Crystalline lens and the ICL lens. And that will probably tell you exactly which lens is tilting. Yeah. High cause of a high vault. See, high vault basically is only one cause, and that is you're done a calculation on a white to white, and you're assuming that the sulcus to sulcus is 1 millimeter more than white to white. What if the sulcus to sulcus is not 1 millimeter more? It is just half a millimeter more or the same. It's a blind area. So your lens would be tight. And once, if this is the ICL, if it is tight, it will vault. If it is loose, it will flatten out. So there's something which is making it tight at the periphery. Either it is not gone into the sulcus, it is somewhere hitting the iris root or something. That is why it is vaulting. But usually that doesn't happen. It slips into the sulcus. So it's the size only that causes a higher vault. Less than 2.8. Yeah, but I would not recommend 2.7 for people who have not done a good series of lenses and have become experts. Because if something goes wrong, how would you refer or take an opinion of another senior ophthalmologist? No. Why experiment with something which is outside the accepted ranges, where you will have to control a situation? You can't seek an opinion of another person.
I have put the spherical, but avoid the tall ICL because the number is the standard power is 0.5.
Yeah. Cylinder 0.5, you can do a spherical ICL, na?
It's working very well 6 months ago. But I am asking can we go for toric ICL?
Yeah, why not? If your confidence is good, yes, because even half a cylinder can be a little disturbing. But if you give incision on the steep axis with a 3.2, it does correct 0.1. But that 0.1 or 0.15 cylinder is so minimal that it's really not making too much of a difference. The difference is when you make a small incision and you are forcing something through that small incision so that the edges are kind of tearing and becoming rough at the cut. But if your incision is bigger and you are not kind of disturbing the anatomy or you're not making it the incision bad at the angles, then the cylindrical change is negligible. So even a side port, which with a irrigation aspiration system, which is making it very tight and causing fish mouthing, will induce more cylinder for a 1 millimeter incision than a 2.2 or a 2.8 millimeter incision where there is no fish mouthing.
How you think the financial aspect in case of lens exchange, second or third?
Financial means we don't charge anything to the patient, and the companies replace it. You just have to give that lens back to them. They assume that once in a while you will land up in a problem because you're putting it in a blind area, and they have provision for that.
But still the company asks for around 10
It depends on your volumes there. If your volumes are low, they would charge. If your volumes are high, they would give it up.
I just got your hydrochlorotation that you just told. I just want to reinforce what you said. I've been doing hydrochlorotation for the last many years. It works beautiful. No reaction, very quiet AC, and no IOP hiccups. And one observation and one question also. Once, for 700 years ago, or even more than that perhaps, we put a lens of a different in both eyes. In one eye, the people didn't come back to normal. It was different.
Yeah. So that is that syndrome. No, what is that syndrome called? Jurits-Zavalia syndrome. And that does not come back. It is because of ischemic changes and it's not rare. We have had almost about 7-8 such cases of Jurits. We say it will become okay with time. Just give it time. It is a question of, in refractive surgery, the basic rule is who tires out first, the doctor or the patient. If the doctor says, sorry, we are done, now best now, nothing can be done, you have to live with it, you have had it. You say, okay, fine, I'm giving you these drops, put it for another 6 months and come back to me. You cannot say that the patient will give up, no? He'll get used to it. He has other things in life to worry about than a Jurits. So refractive surgery, your first principle is you don't admit that something has happened which you can't take care of. The patient, let patient tire out. कितनी बारी आएगा? बोर हो जाएगा. हाँ? हाँ तो उसको दे दो ना कि ओके अभी एक नई दवाई आई, I'm going to put you this medicine. This is known to have very good results. Put it for another 3 months. Show me.
Because of the ischemia, you're pressing on the
It's a ischemia. Yeah. Yeah.
pressure of your
Yeah. It's ischemic.
putting restrictively people after putting FDIC better than not putting pillow.
Come again.
We usually constrict the people after putting the ICL.
Yeah.
Can that prevent this when you're
No. It just happens. Yeah. It just happens. Sorry.
Yeah.
I put it as a routine. Why? Because remember, once you put the ICL in the eye, the AC has become shallow. Right? Very shallow. And the moment there's a little egress or coming out of the fluid from especially the main port, the iris comes with it. So when you are hydrating the edges of the incision, there's a chance that the iris starts prolapsing, and then you have the consequent problems.
I think that can be taken care of on the table. I usually don't do, except rarely when the people is not getting considered in time.
It's a very personal choice. It's a very personal choice. I think almost 60-70% of the people don't use carbachol or pilocarpine. For me, it's become a routine. It works at the spinal level. हल्का सा एक आधी बूंद डाल दी और फट हाइड्रेट किया और बंद कर दिया. And I don't get that iris in the incision, and I'm very comfortable. It's a very personal choice. It's not a must. There's no scientific rationale of saying that you have to constrict the pupil.
Sir, as a general ophthalmologist, what basic thing we should have to do this ICL?
What basic?
Basic investigation. What?
4. Your first 3 are mandatory for calculation. Which is the refraction, the white to white and ACD. And the 4th is retina. Now that is a big issue. We have retina people with us. They can see the peripheral retina and see whether there are any lattices or holes, then they do it.
Is endothelial count mandatory?
Huh?
Endothelial count?
It's not that mandatory. It's not, if you have it, better, but it's not mandatory. It's only retina is important because you have people with high myopia, and these high myopes are prone to retina detachment. Though we say ICL does not induce retina detachment as such because you are not changing the volume in the eye. In RLE, you're changing the volume in the eye. So the big lens is becoming a thinner lens. So there is more space and there's more movement, and the retina can move and detach more easily. So that's why the high risk in RLE. But in ICL, you're not doing something. Instead, you're adding volume, not reducing volume. So the risk of RD is very less. But an RD which happens after you're done an ICL, it may even happen after 10 years. They will blame you. कि जी पहले तो हमारा बच्चा अच्छा बोला था, जो भी हुआ आईसीएल डालने के बाद ही हुआ. नहीं, they will blame if they get an RD before putting an ICL, तो किस ऊपर वाले की मर्जी. लेकिन अगर डॉक्टर ने आईसीएल डाल दिया और फिर आरडी हो गया, 20 साल बाद भी हो गया जी, पहले तो बच्चा बिल्कुल ठीक था, ये तो आईसीएल डालने के बाद ही हुआ है. सो योर गुड रेटिना चेकअप एंड इन द फॉलो अप वी से 1 yearly फॉर द आईसीएल. इट इज नॉट फॉर द आईसीएल. आईसीएल में क्या होना, इट इज फॉर द रेटिना दैट द फॉलो अप इज मोर इंपॉर्टेंट. Shall I continue with the next?
So you have 15 minutes.
Okay, we have 15 minutes. You want me to show you something special, or we have general discussion?
ICL removal, sir.
Yeah. Yeah. Actually, yes. But the thing is, when you're putting an ICL in the eye, you are hoping that probably this vault will be that much that it is not going to block the angle, और शायद काम चल जाएगा, क्योंकि विजन तो ठीक आएगी ना, है ना. एंड पेशेंट विल, इफ यू डोंट डू इट, द पेशेंट विल वंडर कि क्या हो गया, क्यों नहीं डाला. And we know that vaults decrease with time. We show that slide. Why do the vaults decrease with time? When you are irrigating, the vault is not that high because there is a fluid pressure on this thing. The lens has moved backward, the ICL has moved backward, the vault is still acceptable. It's only when the IOP comes down, the whole thing moves up, then you actually come to know that this और ये तो बहुत ही ना के बराबर वॉल्ट रह गया.
So as I had shown, like a lot of high vaults are very well acceptable. They are not causing any problems. So we should not, like, decide on the table itself.
So somebody asked me a question. Why, Dr. Dhami, help me answer this question. Why does the vault decrease over time?
Should I just want to add a joke? You keep on putting a tight shoe in the system.
क्या?
You keep on putting a tight shoe for a few days.
Come again.
You keep on putting a tight shoe for a few days. It gets set. You keep on putting a tight shoe for a few days. It gets set in your feet.
Yeah. It is something like that. Exactly. So the vault is high means the ICL is tight on the ciliary body. ठीक है ना? If the ICL is tight in the ciliary body, it is pressing and indenting the ciliary body. उस एरिया में ciliary body पतली होती जा रही है, कटती जा रही है. You can say in another way, it is the same concept there. So वो जूता सारा फैलते जा रहा है और comfortable होते जा रहा है और vault कम होते जा रहा है. So that is why 300 का vault कम हो गया एक साल में यार. That is the slide we showed you, which is very significant. So I'll just show you a last thing in this, which I think is very significant. Comparing तो मैंने आप काफी कुछ पहले ही बता दिया था. This thing about hydroinsertion and viscoinsertion. So we do recommend again that when you are starting, it should be viscoinsertion. we did recommend that if you can do it, it should be a hydro insertion. Day one, it should not be hydro insertion because you can't focus on so many parameters as a beginner. Some things have to come down to the spinal level to do the other things. So volumes will help you, and ICL volumes are always less. So by the time from one ICL you have another ICL, it could be a month. So that spinal level thing does not develop. So we have come out with another combination for the beginners. And this is what I want to show you. My experience is somewhere it could be helpful for somebody. So we already showed you hydro insertion, we have already showed you visco insertion. I'm not repeating that now. So ICL, when it is inserted under visco, it needs a lot of irrigation to get that visco out from under the ICL. And the excessive irrigation can cause cataract, which Dr. Sarika said. ठीक है ना? कुछ भी कह लो, there is always a tendency when you see so much visco lying there कि यार थोड़ा सा साइड से मैं कैनुला डाल के ये सारा विस्को निकाल दूं. That temptation is always there. You really have to control yourself कि यार मेरे को ICL के नीचे नहीं जाना. That is where the cataract is going to happen. और जितना तुम हाइड्रो चलाते जाओगे तुम्हारा एंडोथीलियम हाइड्रेट होगा, थोड़ा सा कॉर्निया हेजी होगा फर्स्ट पोस्ट ऑफ डे. ठीक है ना? टू मच ऑफ हाइड्रो इवन कॉजेज द कॉर्निया टू बिकम हेजी इन अ कैटरैक्ट. यार कैटरैक्ट जिसमें आपने फ्लूइड खास यूज ही नहीं किया, 50 ml में कर दिया, कॉर्निया इज क्रिस्टल क्लियर द नेक्स्ट डे. और जिसमें बहुत लगे हुए हो हाइड्रो करते जा रहे हो, निकालते जा रहे हो, कॉर्निया में हेज आना शुरू हो जाता है फर्स्ट पोस्ट ऑफ डे. राइट? विस्को इज टिपिकली ट्रैप्ड बिटवीन द हैप्टिक्स एंड द सल्कस. वहां पे हैप्टिक्स की प्लेट में फंसा हुआ है ना विस्को, बीच का तो निकल गया ना, वो जो ट्रैप्ड है वो नहीं निकल रहा, और वो बाद में धीरे धीरे निकलेगा और ट्रबैकुलर मेशवर्क में जाएगा और चोक करेगा. ठीक है ना? वो तो रहेगा ही ना, उसकी फुट प्लेट्स में सब फंसा ही रहेगा. दैट हैज टू हैपन. सो द एडवांटेज इज अ बिगिनर्स एडवांटेज. यू हैव मोर स्टेबिलिटी. विस्कोसिस चेंबर टाइट है, भरा हुआ है, यू कैन डू योर मैनिपुलेशंस आराम से. फोकस ऑन द ICL, देन फोकस ऑन द पेरिफेरल थिंग्स. So even with irrigation under the ICL edge, trapped visco keeps coming out of the central hole. I'm going to show you this video. I'm doing a visco removal and see I'm getting tempted कि side से मैं थोड़ा सा irrigator लगा के under the lens थोड़ा सा visco निकाल दूँ. This is what most of us tend to do. कि वो सामने दिख रहा है visco पड़ा, नहीं निकल रहा, थोड़ा side से घुस जाओ यार, थोड़ा एक jet मार दो जरा सा, which you have to avoid. So even after doing so much of irrigation, when I bring my instruments out, see what happens. अब मैं सारा विस्को निकाल दिया इस टाइम, सारा मैनिपुलेशन कर दी. आई एज्यूम इतनी देर के बाद तो मेरा सारा विस्को हट गया, और लग भी रहा है कि सारा हट गया. राइट? एंड नाउ सी व्हाट हैपेंस. This visco is coming in from those edges, from the haptics which are entrapping that visco in the sulcus, and it is moving in, and it is coming out from the central hole. वो थोड़ा निकलते जा रहा है, and I am just taking a video, और वो निकलते जा रहा है. Dr. Tejas, you said something.
I wanted to make a comment.
अच्छा, just let me finish the video after that. Right? So I do a little irrigation and do it, और फिर और आना शुरू हो जाता है. ठीक है? Can I just finish it, Tejas? And then we'll discuss in the comment, right? A lot of people said कि why don't we use Helon GV? It comes out as a bolus. Problem solved. Right? So we also use Helon GV. It does come out as a bolus. But remember, it is a molecular chain. And a molecular chain can break. ये तो है नहीं कि इट कैनॉट ब्रेक. अगर आप हीरोन जीबी को काट के 2 हिस्सों में कर दो या यूँ खींच लो तो टूटेगी नहीं चेन. टूटेगी तो सही ना कहीं. इट इज नॉट द बाउंड चेन. सो बोलस में निकल आएगा, लेकिन some residual pieces which are entrapped in the haptics could stay there, and when they come out, and clog the drainage channels, they don't dissolve easily. Visco तो फिर जल्दी खत्म हो जाता है. That dissolves very slowly and it causes intractable rise in IOP for a longer period of time. Would you agree with me on that? So that is why even though I tried Heal on GV, but एक तो expense बढ़ गया और एक वो raised IOPs. Huh? Yeah, just a few seconds more. Right. So ICL is inserted under hydro. It has its advantages. The surgery is done in 5 minutes. The total fluid use is just 30 ml in the whole procedure and no immediate rise of IOP. So what we have done is we have developed what is called a hybrid technique. This is the last point. Now what is this hybrid technique? This is for the beginners. Here we put an ICL under visco. Place it over the iris. So the usual steps: under visco, place it over the iris. I'll be just taking 30-40 seconds more. That's it. So this is important. It could be of use to some people. This is the process I was telling you, which we have modified. It's smaller, rounder, grip is good, but it catches the ICL more comfortably. It doesn't push the ICL when it is in the cartridge. So inject 2/3, it opens up. It is over the iris now. Now the second step. Remove all the visco at this stage from over the ICL. There's a big gap between the ICL and the crystalline lens. The ICL is lying loose. There is nothing trapped in the haptics of the ICL. Now remove all the visco from over, और नीचे से भी निकल आएगा बाहर क्योंकि बिल्कुल एसी में पड़ा है ना. There's a big gap around it. And once you remove all the visco, which comes out very fast, there is no trapping of the visco in the haptics, in the sulcus. And now tuck it under hydro in the eye. And this works equally well. It just takes a few about a minute, 2 minutes more, but it works equally well as a hydro insertion. So I recommend now, my personal recommendation, that switch over to this hybrid technique if you are starting. Once you develop more experience, then you can go straight for the hydro insertion. Then your early IOP rise cases will dramatically get over. Dr. Tejas, your question now.
I think it was something similar, but using any beyond definitely makes your job very easy. So I would still go ahead and put it in the visco, but this is what we actually do. We also try to do it. So you answered my question.
Thank you. Thank you. Right? And thank you so much for attending this IC and being such a lovely audience.